Good morning. And I'm really excited for this next edition of the SMA Dialogue series coming to us live from Washington, D.C. One of my good friends and colleagues, Professor Aaron Henry, who is on faculty, a professor at the George Washington University in the School of Medicine and Health Sciences. Really excited to have you here, Aaron. What's going on? How are you?
I'm doing great and just want to thank you for having me here today. It's a great experience and definitely a big fan of the cause and excited to work with you in the SMA.
Man, we're really excited to have you. It's been quite the summer. It's been quite the year. I think we've all been trying to navigate a lot of the different policy landscapes in health professional education and health workforce. One of the things that we've talked about is just the changing landscape in the PA world in particular. And I wanted to kind of talk to you a little bit about that. I also want to make sure that I get a chance to kind of hear a little bit more. You had a commentary piece, Why Black Men Are Dying to Be Successful, that I actually thought was, for many reasons, really salient and really interesting. So I'll come back to that in a little bit. But I mean, first, we'd love to just be able to kind of hear a little bit about yourself so that people know who we're talking about, a little bit about who Professor Henry is.
Sure. So my name's Aaron Henry. I am a PA. I've been a practicing PA for going on 16 years now. Before becoming a PA, I was a combat Navy corpsman. I served two tours of duty in Iraq. Just always have had a love for science and I loved engaging with people. So pretty early on, I figured out that the healthcare route was for me. I was on the fence between actually was going to be an athletic trainer. My undergrad is in sports medicine, but when I was in the military and I believe it was on my first deployment to Iraq, I met a PA and I was like, wow, that's what I want to do. And I was on the fence between med school, PA school, and I talked to a couple folks and they're like, PA is a really good field. And the first PAs were Vietnam era trained Navy corpsmen, so there was just so much alignment and history there. And I got out the military, got into GW, graduated from the program class of 2010, and I've worked in emergency medicine directly out of PA school, pivoted into urgent and primary care, and developed an interest in men's health. And actually got my health coaching certification, started a men's health um, YouTube channel, wrote blog posts. Around the time of COVID, I started to get a little burned out.
Hmm.
And after graduating from PA school, I would always precept medical students. I would stay aligned with the PA program and I would teach lectures here and there. And I knew at some point I would want to return to teach. And there was an opening, you know, the stars and planets aligned, and I got into faculty in 2022. And I still had my passion for men's health, especially Black men, seeing the disparities. And I enrolled into the PhD program at GW in translational health science, where my work focuses on improving Black men's health through bridging the trust gap between Black men and healthcare providers to improve access, build stronger relationships, to decrease those preventable chronic illnesses that go under the radar because a lot of them just don't feel a connection and don't want to go in and get those preventative screenings. So that's sort of the, I guess, Cliff Note version of what got me here, a little bit about my background. And then with SMA, the mission and healthcare workforce, it just all made sense. So I'm really thrilled about it.
No, we're thrilled to have you in this space, and appreciate you being able to kind of detail some of your background. One of the things that you mentioned that I actually find to be really interesting is about, and you mentioned this in that "Why Black Men Are Dying to Be Successful" commentary piece. I had a chance to read it actually. I was reading it again this morning on the train, and there's a couple of things there that I thought right off the top would be excellent to be able to kind of get your perspective on. You actually just mentioned on one of them, which is this idea of mistrust amongst providers or the healthcare system and Black men in particular. I know that that's an area of focus of yours. But the second one, and this feels like, this is kind of like a multi-layered thing here. You also kind of talk about all of these different sort of structural determinants of health that have nothing to do with the actual care delivery system, with access to the provider, to the interpersonal relationship between a Black male and the provider, but
Mhm.
simply the conditions that Black men exist in the United States and how that actually affects the health. So we're talking, at least my interpretation of the way you wrote this, which I thought was a really like terrific piece, is that we're dealing with a couple of different levels here when we're talking about Black men and health, which is one, those structural upstream determinants, and then of course more downstream the relationship with the healthcare system. So I'm curious. I want to dive into both of those for just a moment because I'm
Sure.
curious about your perspective on each of those. So maybe we start with the piece that I think a lot more people are a little bit more familiar with, which is the direct experience with the healthcare system and even individually with a provider.
Sure, sure. So for those who didn't read the piece, I wrote a commentary talking about the paradoxical relationship between Black men of higher socioeconomic status and poorer health outcomes. In most cases, higher pay, higher salaries, more wealth usually equals better health for most populations. You have better access, can afford the drugs, you can afford more access to providers essentially and higher quality care, if you will. But what research found, there was a study that I quoted in my paper that showed that Black men who have the higher socioeconomic status, I believe 200% higher than the federal poverty level, actually have poorer health outcomes, especially compared to white counterparts, and for a variety of reasons. And that goes into the structural piece that you talk about. And there's a term that we've heard of and known, intersectionality, where we look at how various social characteristics ties into someone's identity. So, for example, in especially Western society, being a man is often looked at as having privilege. Men make higher pay than women. I mean, these are things that we know. But when you throw race in there, being a Black man, it's often perceived as, okay, you're a man, you make higher pay, but when you intersect with race and how discrimination plays, that can have a negative effect. And for men of higher socioeconomic status, being in those spaces where you don't see other people like you as well puts a lot of allostatic load on someone to perform better, to provide for your family. You're working harder, taking on extra loads, which takes a toll on your health with sleep, cortisol, stress levels, poor eating, not exercising, not spending time with family. So that's what I wanted to touch on and really show don't assume because someone has a six-figure salary that they're in good health. You have to look at the person, the whole picture holistically. So that's what I touched on that piece with those social determinants of health,
Yeah.
how those things intersect.
I remember, early in public health training, hearing all of the different examples of, we were always taught about like different correlations and associations between, different demographic factors and race, ethnicity, and kind of how we look at associate relative risk of certain illnesses and what the incidence and prevalence rate is of across different conditions. And I remember, thinking like one of the most common examples that we had always kind of talked about is that Black women in particular, um, you know, income and socioeconomic status is not, in fact, modifying factor for for adverse health conditions, particularly as it related to, of course, I think maternal morbidity and mortality was often seen as being the that example that was being used. It's so wild to me that there's all of these different factors that are in play, and you talk about intersectionality. Those I mean, you just mentioned a couple. There are so many other conditions and circumstances by which people are living in that also have some type of modifying effect, right? Urban, rural,
Your
the
environment,
zip code,
absolutely.
exactly, right?
Yeah,
Yeah,
absolutely. But then as we touch into what SMA and Mullen Institute talks about, healthcare workforce, how is the healthcare workforce who largely isn't don't come from minority
yeah,
backgrounds deliver care to populations that historically are less trusting?
yeah.
How do you do that? Because
Well,
that is a barrier. Mhm.
so I mean, so that's an interesting question because I think, and that actually leads me to sort of like another point that I really want to get your take on this. Often. one of the ironies of the work that we do, especially as it relates sometimes to specifically to workforce diversity, is this idea of, part of our goal is to, increase the diversity of the healthcare workforce, increase the number of underrepresented minorities who are in these spaces, because we know that that is actually a protective factor for community health and a benefit at large for all people, not simply for a specific group. It actually is of benefit to the entirety of our country and of our society to improve the health of communities that have been most marginalized historically, right? Um, but with many of the different sort of methods that are used to address like these longstanding inequities, it's easy for some people. And I've seen, we come across articles on this. We hear it in some classrooms. We've seen all these perspective pieces on it. Some people then, I think, maybe falsely equate that with, oh, I've interpreted that as a white physician or a white PA or a white nurse practitioner is not capable of providing quality care to a black patient or to a black community.
Right.
That's not necessarily what we're saying. Is that accurate to say? Is that correct?
Absolutely. What I see, and especially being both someone who's been in the field and worked in emergency medicine, urgent care, primary care, engaged with different healthcare providers, different populations, then also being in health education.
Yep.
The issue is that a lot of healthcare providers aren't trained how to build trust. And that's my focus. There's talk or there are sessions in medical school, PA school, that talks about social determinants of health. In fact, I'm teaching health justice and society for the PA program, taking over for Dr. Howard Straker, who's been mentor of mine for, since I was in PA school. So those courses exist, but what about how to engage with these populations? We learn anatomy, physiology, pathology, histology, but what about those interpersonal relationships where that matters the most? No matter how smart you are, how quick you are to come up with a diagnosis, if you can't connect with the patient, how is that going to work? So I think it needs to start there in the health professions. Yeah, there could be workshops and training, and there have been many methods to try to um, resolve, bias and discrimination, but it really, I believe, in my opinion, starts in the health education. It starts while they're learning those basic sciences, learning how to engage with people.
Mhm.
Because we can't solve the lack of representation in the health professions overnight.
Yep.
For example, for the PA profession, less than 1% of PAs, practicing PAs, are Black men. That's not going to change overnight. Then when you look at the political things that are happening now, but what we can do is design interventions, design curriculum to train those before they get out into the workplace, especially while they're very enthusiastic about learning about medicine, because we all came into these fields to help people.
Hmm. Yeah. No, well said. Well said. And I think um to kind of tie that up, the false equivalency around racial concordance between, providers and patients being the end all be all for how we, resolve patient trust. I think it's been overstated, and I don't think it's accurate. I don't know if that is what many people are calling for when they've talked about diversifying the healthcare workforce. I think it really has been it's a this and, right? It's a recognition that we do need more providers of color, and exactly what you've just touched on, those who are already in training, there are opportunities for those students need to be properly equipped to be caretakers and healers and thoughtful, conscious thinkers when it comes to patient care, and not just on the patient care side, right? But also in terms of those of us who work more on the systems and policy side, and those of us who don't have, don't see patients, but still have influence on the way that patient care is actually delivered. Um, that's a lot of kind of what's going on within, sort of the clinical training component of this. I want to take a quick step back though and kind of talk a little bit more broadly about the big picture of it all. The healthcare system, um, and you talk about mistrust. And I think that something that I know comes up in conversation pretty often in my space is, there's something about where we are right now as a society that there's just a general mistrust in a lot of institutions. There's a lot of mistrust in a lot of systems. When I say like institution, I'm talking about like, the institution of education, the institution of like scientific research, right? Like, the institution of American politics, the institution of government. There's so much mistrust now, and for a multitude of reasons that we could probably point to, right? There's misinformation, active disinformation. I would argue that we as a society maybe don't necessarily value some of the things that maybe we took for granted a little bit more, like you know reading. I don't know if it's really still reading and writing. Who would have thought? I don't know if those things are still being placed in the same level of value as they were, say, 15, 20, 25 years ago. That's debatable. I'm always curious to hear other people's thoughts on that. But like, what do you think are some of the reasons for this general mistrust, both in terms of the healthcare system, in terms potentially of a provider, but then also like, what does that say about the bigger the bigger concern of mistrust in society, and how can we address that?
Well, I think you touched on a couple of big things, and there's a lot of mistrust. Just you can't deny it. I mean, the data is out there for minority populations for a variety of reasons. Historically, there have been things. I mean, Tuskegee is often quoted, but sterilization of Black and Latino women, back in the days,
Hmm.
just so many things. Look at, you know, denial of entrance into medical schools or professional associations, people of color not being admitted, leading to things like HBCUs and medical schools for people of color. That's already there. That's documented, and unfortunately, it still goes on today. And the sad thing is that, especially in this day and age, the political environment is essentially throwing gasoline on the flames. It's exacerbating these disparities and this lack of trust. But then what you mentioned, lack of trust in sort of the things that were traditionally accepted as evidence-based, reliable sources of information. Institutions like the CDC, NIH. I mean, now you're seeing political rhetoric thrown into these institutions, which for me, when I saw, you know, this is shut down due to XYZ party, I'm like, what is going on? So all of that confusion and additional rhetoric from certain political folks who throw their personal spin, not evidence-based, people listen to that. For some people, their only source of information is social media or certain news stations, and they're going to take that as law and discredit all the work, all the decades of evidence-based medicine that has saved lives and kept populations healthy. So this is a very fragile time for medical schools, schools of public, what we do for providers, for health policy advocates, because we're combating so many things on the individual and on the legislative level,
Hmm.
which is dangerous. But we need people to hold the line and debunk these things. But it's tiring. Healthcare providers are going with a patient, and you have all the evidence, you've talked to them, you've got a good history, you have objective findings from lab or imaging. Some patients will say, no, I don't think this is what it is, despite having evidence there. Now you have to listen to patients and take their perspective, but it's very dangerous if we're not taking vaccinations or medications which have been proven to be safe and can help you. But if you have political figures or, popular figures debunking these evidence-based things, it becomes a big problem.
Yeah, yeah, it undermines a lot, and it makes it. If you have noise coming from every direction, it makes it very difficult to understand where to be looking at,
Right.
where to be listening to, and who to be listening to. And yeah, it's unfortunate that I think there are bad faith actors in society who have some type of incentive to discredit some type of either existing or budding system or voice, including those that honestly have been at the heart of public safety and public health, which is really unfortunate because that's the most vulnerable component of any society is the health of the public, right? Which is the reason why public health and all of the systems that make up the constellation of public health are so important. And that includes, the workforce and these different systems. Yeah, the medical system. the education system that leads into that. Um, Without question, I couldn't agree more. Let me ask you this, because I think I mentioned before the Why Black Men Are Dying to Be Successful commentary, which I do encourage everybody to go out and read. It's an excellent short read, but really a lot of it packed a punch. And I think that one of the things that I picked up from it is something that you actually mentioned at the top of this talk, which is around burnout. And I know that you'd even kind of given an example, it's interesting as I was reading it and then listening to you talk now. I don't even know if I think at the beginning of the commentary piece, you kind of described your mom and her working a couple of jobs and how normalized that was. And it almost felt like a little bit of a, oh, that's not even the burnout that we were talking about. Like it's almost like that was an implied burnout. The burnout that we actually ended up talking about was something entirely different from the burnout that was prefaced at the beginning, talking about your mother and how she had to work these two jobs and how that was just normalized across, your neighborhood and your community. It's like, oh, okay, this is really meta now because now you're talking about
Exactly. This is normal.
even
Right.
if you point out that burnout as being sort of like that wasn't even the main thesis of the commentary. It was other burnout. And you talked about it, you mentioned a few minutes ago, as you were talking about your background and your training, how you were burnt out. You said that word like, right off the top. So I'm curious to know, as you kind of think about your own personal story, the professional story, the experience that you had growing up in the neighborhood that you did, and with the experiences that you had with your mom, um, uh, and then part of what we're now talking about with some of what causes burnouts. I mean, how do those things, how are all those things connected? How are your views shaped?
Yeah, so like I said earlier, we go into healthcare to help people. When I imagine being a PA, it's like, I'm gonna see my patients have time. I was really, well, am really big into fitness and like I said, sports medicine is my undergrad, really transforming lives and living healthier lives. And I imagined sitting and having time with my patients and really delivering not just the Western medicine and diagnosing and here are your prescriptions, but hey, let's get you off of these medications. Let's understand why you have hypertension or diabetes. But the reality is what I quickly learned that that's not how it works in our healthcare system. There's such a demand for healthcare, shortage of healthcare providers for one, and then also just the model of healthcare payment, the insurance system, um, the third party billing, and just the rapid. It becomes almost a hamster wheel where it's a business. Healthcare becomes a business model where you have to see a lot of patients to generate revenue. For example, I worked in an urgent care center in one where I 14-hour shift I had. In 14 hours, I saw almost 90 patients. Almost 90 patients. In family medicine, where you think, okay, well, that's where I'm going to have time to sit and talk to providers. I've had friends, PAs, MDs who are seeing 30 patients, which is you're seeing like there's certain quotas, 4 patients in an hour. So how do you get a good history? How do you get to know someone in 10, 15 minutes? In emergency medicine, the ER, that's kind of understandable. That's the name of the game there because the goal is to identify life-threatening illness, take care of them. But family medicine, which is often quoted as the gatekeeper, you need time to talk to people. And even in my research, uh, that I'm doing for my PhD, looking at the barriers and facilitators to trust for Black men and healthcare providers, rushed encounters, being dismissed. Those are all big, those are big themes about negative experiences and things that perpetuate mistrust. So, at a systemic level, I think that creates burnout. It really does because providers working in those systems have these quotas. Then you throw in the billing and the coding and the documentation. So it becomes more of administrative work, crossing your T's, dotting your I's for billing, and so that you don't get sued, essentially. So
Right,
then how do you then factor in or build in trust with the patients if you're running back and forth and it causes burnout? It
right,
causes a lot of burnout for providers. In fact, in looking for stats for MDs, suicide is high in the healthcare profession. There's a lot of moral injury. There are a lot of psychological toll that I think isn't talked about a lot enough.
Yeah, no, I mean, I don't know anybody who hasn't had some type of experience or story that they can kind of share about, people that their provider missing something, missing the mark, missing something. And, you know, those of us who work in this space probably have a better understanding of what some of the reasons are for why these things get missed. And you kind of talked about some of that, the amount of time the number of patients and the amount of time that can be allocated to each patient. The reality is that, our communities and our patients, they don't see that. They don't care, and they shouldn't. The system needs to improve, right? It shouldn't be a situation where we're, simply focused on educating and informing the public as to why these things are issues, why their provider only has the physician only has X number of minutes to see them. Um, that can be a band-aid, but the reality is that the system needs to change. It needs to be improved.
Absolutely. Absolutely. And then that will help patients and providers. So that one thing, changing that one model, will these big corporations take a hit financially? Yes, but it's what matters the most, delivering quality care, you know, preserving the health, especially mental health of your providers so that they can do their jobs properly. Those are big discussions. And it takes bold action to do that or to
Yeah,
mention it.
yeah, no question about that. I'm gonna get you out of here on this because I know we're just about at time. And maybe you were about to segue into that a touch. What do the people need to know? What's the message from Professor Henry to the network?
So I think I would just, you know, bring in what I just said. It takes bold action, bold decisions, because we're in some very interesting times right now where not only evidence-based knowledge is under assault, universities are under assault, diversity is under assault, even to the level of admissions. Decisions made about caps for tuition assistance affects who can apply,
That's gonna have a major
who
impact.
can afford it.
It's gonna have a major impact.
And then have to look at, okay, those folks who get admitted, how likely are they to go to underserved populations or populations that aren't lucrative or fields that aren't lucrative? So then yet again, you'll have a deficit in the primary care fields, which historically have been paid the lowest, but are so critical for identifying these diseases and preventing diseases before they get into the ICU, before they get into the ER, before they get into the morgue. So I think we collectively, educators, clinicians, public health leaders, legislators, need to reimagine the healthcare system, the healthcare model, and really see what's most important. Because a sick nation it's dangerous for everyone. A healthy nation is a strong nation. So I would say that's my message.
Well said. Well said. Listen, really appreciate your time. Aaron Henry is assistant professor and co-director of clinical education at George Washington University, the PA program in the School of Medicine and Health Sciences. Aaron, I appreciate. Oh, I'll let you out on this before I let you go. You're gonna have to solve this a debate. Physician assistant, physician associate. Those of us who don't work in that space always curious about the preferred nomenclature. I noticed even in the article you had a little bit of a slash between the two. Are you able to give guidance to which of those two should be more socialized and normalized, or do you want to abstain from providing input on
Yeah,
that?
I would leave that as TBD.
It's TBD.
It's ongoing.
It's an ongoing conversation in the field. That's helpful. I think it's actually helpful for those of us who are not PAs to have insight into some of the fact that, hey, these things are still being kind of sorted out and direction is being better understood. So I appreciate you giving a little bit of insight on
No
that.
problem. What I will say about that is, I think we get so caught up in the names and a lot of ego, a lot of things come into play. But again, what is the mission? It's to take care of our communities, to take care of our people, and we work as a team. As a team. So I'll let the higher powers that be figure out the nomenclature,
And
but
we'll focus on the
that's
work
my
right here.
message.
That's well said. Well said. I appreciate you, Aaron. Thank you so much for the time. And thank you all for tuning in and listening. And we'll see you next time.
Thank you.
Thank you.